Colleagues, welcome to the We Move Adolescent Health webinar hosted by the Desmond Tutu Health Foundation and IAVI. My name is Tian Johnson. I'm the founder and lead of the African Alliance, a queer-led African health rights nonprofit working across the continent, and I will be chairing today's session. Thank you all for joining, and let's get started. This is the fourth webinar in the We Move series, following hot on the heels of the first three, which you will recall kicked off with looking at adolescents at the intersection of COVID and HIV, the second on mental health and well-being, an area that continues to need our collective attention and support, and the third discussion on SRH integration, and what looks like and how integration manifests in reality when the rubber hits the road. In today's session, we are going to be focusing on gender and sexually diverse populations. Colleagues, we will start by hearing from a diversity of voices, of researchers, activists, and artists who in all their circles of influence and authority make critical contributions to how we individually and collectively understand the realities of gender and sexually diverse populations, how we can leverage the power of implementation science to improve programming focused on LGBTQIA+ communities, learn more about the link between urban health and queer development, and taking us along that journey will be Professor Stefan Baral, Neil Hassan, and a powerful artistic interlude from Tandile Mbatsha. We will then use the space for some reflections on those presentations, and to that end, we will hear from three thought leaders in the space, and that will happen in the form of a panel discussion, where our two speakers will be joined by Dr. Anastacia Tomson, Amelia Mfiki, and Dr. Zoe Duby. To start off, we'd like to get to know you all a bit better by answering a quick poll question. Please look out for the poll, which will appear on your screens now, and complete it by clicking on your preferred responses in the next 60 seconds. And again, welcome from all of us. The poll should be appearing on your screen now. If it has not popped up on your screen automatically, please do click the icon that says poll. There's a question in there that asks, do you feel that you personally have an understanding of the issues faced by gender and sexually diverse populations? Your choices are yes, no, not sure.
Sorry, Tian, we are having a slight technical error with the poll. If you could just give me 2 seconds to rectify that.
I see it's now working, Carrie. I'm seeing responses coming through.
Oh, great.
A very active group. I can see a lot of responses coming through. Thank you, colleagues. Keep them coming. We'll wrap up at the top of the minute. It looks like most answers are in. We'll run it for a few more seconds. I can see there's still more people joining us. Keep those answers coming, colleagues. If you can't see the poll question that has popped up on your screen, please do click on the poll button at the bottom of your Zoom interface, and you will be presented with a question and 3 answer options. Wonderful, we've reached the top of the minute. So about 60% of you have said yes, you do feel that you personally have an understanding of the issues faced by gender and sexually diverse communities and populations. 12% said you do not, and 27% said not sure. We hope by the end of this conversation that might change, but let's see how that goes. Colleagues, I'm now going to introduce the first speaker. I just want to do a quick check with Carrie if Professor Baral has joined us.
Hi, Tian, not yet, but we can start with Neil's presentation.
Wonderful, just give me a second. Neil Hassan is a researcher at the African Center for Cities at the University of Cape Town, a queer political activist whose creative and academic interests interrogate how urban development of spaces and places call people into being, and how politics of identities, with a particular focus on gender and sexuality, influences holistic health and well-being. Neil's current work interrogates the urban development strategies related to HIV policies across scale, global, national, provincial, and municipal, and how health policies are adopted, adapted, and implemented among key HIV-affected and infected community groups, such as men who have sex with men and LGBTQI communities in Cape Town as a city imperative. He will be presenting today on making space for safer connections, urban health, and queer development. A reminder again to participants, please do keep the questions, reflections, and comments coming in the chat box, and I will now hand over to and welcome Neil Hassan.
Hello. In this presentation, my aim is to consider an integrated framing for urban health intervention among key HIV-affected and infected populations, or KPs. In order to do this, I first draw from MSM HIV-related community engagement work in Cape Town. Thereafter, I consider its application for KP and LGBTIQ via urban linkages, namely health, education, and community-based queer development, to further consider identities of belonging in space and place. The points I wish to make is that queer-related health programming in Cape Town reinforces along lines that segregate conceptually and spatially. For example, men who have sex with men from sex workers, people who inject drugs, and those in prisons from lesbian, gay, bisexual, trans, intersex, and queer communities. NGOs are also siloed along these fault lines. While each health category or grouping has unique factors contributing to HIV risk and vulnerabilities, within and across Cape Town-based townships, MSM, KP, and LGBTIQs share common socio-spatial factors, which are also largely relational, situational, and context-driven. Stigma, discrimination, poverty, unemployment, school dropout, and adverse mental health conditions are all highly prevalent among MSM, KPs, and LGBTIQ in Cape Town-based townships. Given this, we are desperately requiring models of health that are practical and responsive to the complexities of real-world situations, capable of acknowledging, framing, engaging, linking, and integrating HIV vulnerabilities, those deeply embedded in specific spaces and places. Against this background, in 2016, I was involved with researchers at the Department of Psychology, Stellenbosch University, to examine community engagement practices in HIV vaccine programming at a research NGO in Cape Town. Part of this was to understand the varied experiences among township-based MSM who participated in clinical research, such as pre-exposure prophylaxis clinical trials at that time. Evidence suggests that community engagement strategies are highly effective at linking the NGO to MSM and promoting uptake and adherence to HIV research, clinical programs, and psychosocial behavioral interventions. Importantly, relationships between the NGO and MSM, among MSM as a collective, and their collective engagement in HIV programs can buffer against factors that challenge adherence to HIV programming, specifically because of the deep and close relationships that are formed. One such intervention has been the emergence of MSM safe spaces. To provide some background, each safe space has an elected leader, an executive body with at least a secretary and/or a treasurer, and affiliated members forming social clusters as little as 6 or as many as 50 or more at different key points in townships. MSM safe space leaders, for example, are particularly well known in their communities and connected to a range of community-based stakeholders such as local businesses, school principals, and governing bodies, religious, spiritual, and gang leaders, ward councillors, and other political representatives, police services, and activists. They also represent their respective communities as part of advisory boards for HIV-related policy and research activities, and deliver, in partnership with NGOs, many health-related activities and events to promote safety and health in and around the city. For example, from an earlier publication, a safe space leader discussed his involvement with the Western Cape Education Department's ongoing initiative to recruit teaching assistants at public schools. In this quote, the participant, like many others, explained how many in their communities especially young school learners with much enthusiasm seek advice regarding being queer, asking, how do you remain being yourself in a community like ours? How do you remain yourself? Via MSM HIV-related community engagement, it is evident that safe spaces encourage very important linkages in urban spaces. Safe spaces also promote opportunities for training and spatial innovation for and by youth leaders or role models who visibly perform with pride their diverse gender expressions and sexual identities. These findings are relevant to other KP categories and LGBTIQ identities who require health innovation in a city like ours. Taking my lead from this body of work, in 2018, along with Dr. Andrew Tucker, we joined the Peak Urban Program and were tasked with examining potential pathways to making cities inclusive, safe, resilient, and sustainable, based on the United Nations Sustainable Development Goals. Theoretically and tactically, Peak excavates the critical and complex global-local relations that contribute to socio-spatial health challenges, climate change, migration, and informality in places that are rapidly transforming, such as African cities. Our aim to expand on examinations of MSM HIV community engagement practices, focusing on queer diversity among Cape Town-based NGOs. Worth keeping in mind is that many of these groupings, MSM, KP, or LGBTIQ, are arbitrary in defining, confining, and segregating concepts or identities. For example, the WHO also acknowledges that many individuals will relate to more than one KP. Some MSM and some transgender people may also engage in sex work and or inject drugs or other substances, as is the case in Cape Town. What follows are two themes related to the governance of HIV-related interventions in townships across Cape Town, based on qualitative interviews with 27 community members from a variety of township spaces and 10 LGBTIQ NGO staff members. All interviews were one-on-one, audio recorded, transcribed, verbatim, verified, and analyzed for themes. In many of the interviews, participants relayed that safe spaces changed dramatically. Previous MSM only, now safe spaces have engaged other KPs such as trans, lesbian, bi, and queer women, sex workers, and adolescents. These are not without their challenges. However, the safe space expands even further with activities such as group therapy involving parents of safe space members at a much larger scale than previously. I'm also told that youth leaders and safe space members themselves, now somewhat independent from NGOs, but not entirely, are also developing and delivering their own HIV interventions and social justice movements. And that youth as young as 14 are joining safe spaces in townships led by MSM, gay, bisexual, queer men, and trans women. There are now safe spaces further beyond the city centre and well beyond boundaries where they initially started to. One NGO staff member, however, on legal and ethical grounds, mentioned that even though safe spaces are attended by those younger than 18, they, NGO staff and HIV outreach workers, cannot assist outside of parental consent on the one hand, which is in itself a very delicate matter, and on the other hand, because many past and current LGBTIQ HIV programs among leading NGOs are not funded or designed for KPs younger than 18 years or for integration across KP and LGBTIQ. As an example, an NGO outreach worker conveyed his anger at the education department when it came to dispersing HIV-related sexual rights and reproductive health material in public schools. He said, "That's why I'm so upset with the education department that it's not allowing us within schools to give the right information at the right time for people. Because now you have completed matric and they have a little information about HIV, STIs, which is so wrong. Then they come to the real world and their first sexual encounter, boof, gonorrhea. So where is this conversation in schools?" This represents a powerful linkage between safe space members, teaching staff, and school learners. It also represents spatial restrictions and missed opportunities between systems of health and education, especially for those who have already been role modeling queer identities, and promoting HIV-related health education in their own township communities. Queer role modeling, however, in townships are not without the threat of adversity, as we also discuss in the 2018 article, via paradoxes of health. This final quote was received from an NGO staff member who focuses on clinical HIV service delivery. It highlights the incommensurability between policy, institutional practices, and health activism. I think every country has to have a strategy, and we'd be lost without strategies. We've got to have them, but how often are they reviewed within that time frame? Do things change if it's not working? I don't think so, because otherwise we wouldn't have these young women coming through now that are positive. Everything is focused on MSM, and yet if you look at young women, now is the highest number of positive people in our population. What is being done with men about that? Because if you are 15 and you are HIV positive, that's under the legal age of having sex. South Africa has very robust legislation and policies that we can draw on to make claims, to prioritize appropriate and effective health interventions, and to garner constitutional protections. Across governance scales, be it international policy, national, or provincial, our examinations of MSM only and KP integrated HIV programming reveal attitudes of neglect toward Black and colored lesbian, bi, trans, and queer women. In a recent article, Tucker and I argue that this neglect is partly resulting of international funders, such as PEPFAR, who have predominantly prioritized enormous amounts for MSM in HIV interventions in Africa. We also argue that funders and donor agencies, those who fund HIV intervention in the Global South, do not consider how MSM exists as part of potentially wider and politically powerful networks. Engaging, monitoring, and evaluating MSM, KP, or LGBTIQ programs along a single axis of identity only, be it gender or sexuality, can highlight and elide real-world experiences in local contexts, preventing responses in local spaces by those that govern at a distance from international or national scales. In conclusion, whether MSM, KP, or LGBTIQ, we do acknowledge unique health experiences among and between individuals, but the situational and contextual factors underpinning health challenges do overlap within and between a variety of townships, also due to apartheid spatial planning that segregated communities along race and socioeconomic status. A practical, social, and spatial ethics is still required to reformulate theory, practice, and policy via circular, community-based, and peer-driven feedback systems. Such programming can aid social justice and urban transformation in a city such as ours that is now having to reconfigure the siloed effects of MSM HIV programming. In resource-restricted and socially isolating contexts, adapting and adopting policies that originates in the global north can be difficult in the global south. And as we were told in the previous webinar, precisely because extracting what works for whom and under what conditions require experts and time to trial and error. Peer-driven and socio-spatially embedded interventions are useful and sometimes the only options we have in context of poverty and resource restrictions. How we position youth, their diverse gender and sexual experiences requires attention to voice in the spaces and places that they occupy. From these perspectives, we may even better program against gender and sexuality-based violence, school dropout rates, experience of rejection and isolation, and increase uptake of highly effective socio-spatial health programs. Such activities may even better contribute to controlling HIV/AIDS in our neighborhoods and homes, among our friends, and places of work and learning, potentially transforming systems that govern queer lives and livelihoods. In order to do this, we require realignment of macro policy with local practices. via peer-driven and community-based integrations, those that enable people in enabling environments via accepted, respected, and dignified queered collectives. And finally, thank you so much to DTHF and IAVI and for your attention.
Thank you so much, Neil. Such a powerful expression of what meaningful engagement means and could mean. The importance of linkages to support and the power of peer engagement. And so thank you for allowing us a glimpse into that critical work that you do and reminding us of both the beauty and the complexity of intersectionality. Colleagues, both of these presentations have been pre-recorded. Both presenters, though, are with us in the room, and we will engage with them and the presentations that they have and will be sharing during the course of this webinar. We now move to our interlude. Tandile is a queer and gender non-conforming performance artist, choreographic activist, educator, speaker, host, producer, model, and scholar based in Cape Town, South Africa. Tandile, a very warm welcome to this space, and I will hand over to you now to introduce and contextualize your work briefly before we screen it.
Thank you so much, Tian. I'm Tandile Mbatsha, as Tian has said, and the name of the work is Mbambos Nomongo. Now, Mbambos Nomongo is one of my clan names, is Thakazelo Zasekhaya, and the statement goes as follows. Ndingumzangwe, Chai, Unjanana, Untelele, Untubi, Uzongozi, Msuthu, Studu, Ndlanga Litafa, Madlozi, Mbambos Nomongo, Ndiyazalwa intombi yasemaqwashini, ugqiya umvambo lawo, umanzini, usiaphi, tikayivumi. In this work, I do the work of self-identifying as a Black, African, Xhosa, and queer person. This work is on the back of my reclamation, the work of recovering and remembering with self. Queers of color are in real and constant danger because they are not seen to belong neatly to either Western queer culture because of our Blackness, or to African culture because of our queerness. This discursive violence legitimizes actual violence on Black queer bodies. Basically, in this work, I'm just reclaiming and asserting myself as a Black queer Xhosa person with and everything in between and nothing at all at the same time. So please enjoy. Thank you.
Nakupumizo nos amigos, nakupumizo nos amigos. Yeshambulul, yeshambulula, yeshambulul, yeshambulula. Nakupumizo nos amigos, nakupumizo nos amigos. Yeshambulul, yeshambulula, yeshambulul, yeshambulula. Nami nje ngingedwa cela ukuthatha leli thuba. Cela ukuthatha leli thuba. Nami nje ngingedwa cela ukuthatha leli thuba. Cela ukuthatha leli thuba. Ukuthula kubazalwane. Nami ngiyayibonga inkosi esangcinile. Kukoko ngithola indoda. Yenza ubudoda. Ngiyawazi amadoda. Dodi wodwa. Ukuthula kubazalwane. Nami ngiyayibonga inkosi esangcinile. Kukoko ngithola indoda. Yenza ubudoda. Ngiyawazi amadoda. Dodi wodwa. Dodi wodwa.
Tandile Mbatsha, thank you so much for sharing that piece of work with us, really just reminding us about the power that we have when we claim our space and the many, many layers that make up who we are as members of this community. Thank you so much. Colleagues, Stefan Baral is a professor of epidemiology and director of the Key Populations Program at the Center for Public Health and Human Rights at Johns Hopkins University. Today, he will be presenting on leveraging implementation science frameworks and approaches to improve adolescent LGBTQ+ programs. A reminder again to please keep the questions, reflections, and comments coming in the chat box. I will now hand over to and welcome Professor Baral.
I want to thank the organizers for inviting me to speak virtually today. Obviously, I think as with others, I wish we could be in person. But I'm really excited to be part of this panel. My talk is going to be a little bit different from having reviewed the past We Move sessions, and I really want to kind of focus on methods and sharing some methods elements. And so the title of my talk is Leveraging Implementation Science Frameworks and Approaches to Improve Adolescent LGBTQ Programs. I really want to try to achieve as much as possible today. And so there's really 5 things I want to talk about in this short talk. So one is the characteristics of implementation research methods. The second element I'm really going to talk about is how we measure implementation. Third, I'll talk about some implementation research designs. And then I really want to talk about the state of implementation research within stigma mitigation, because I think that is something that's particularly sort of near and dear to a lot of the interests of a lot of the folks potentially listening. And then some closing thoughts. I will also apologize for going quickly, but I think the advantage of a recorded talk is if folks are interested, they can always go back for more. So I'm going to start by talking about the characteristics of implementation methods. So this is a visualization of the traditional research pathway with sort of on the y-axis, you see increasing real-world relevance, and on the x-axis, you see time. And I think a lot of our work starts out as that sort of pre-intervention work. And from a programmatic perspective, it's really asking that question, like, could a program work? And that is a lot of animal studies and phase 1 and phase 2 type studies. When we think about sort of the T3 and T4 studies, these are normally, we've gone from efficacy studies now to effectiveness studies. And so we're really asking, does a program work? And so when you hear about people saying, listen, effectiveness is really about real world data, we're asking, does a program work? Implementation research is sort of the next step is, okay, you've identified the barriers to the program working, and now you're studying ways to try to improve upon that. And Aaron's presented a framework that I think is useful, where there's sort of 4 phases of this work. First, looking at exploring, so trying out and thinking about what are these different ways that you might improve a program, preparing for it, actually doing it, and then thinking about strategies to sustain it. And all of that is ultimately getting to that sort of real world relevance and generalizable knowledge. But that is really what we're trying to do here in the context of implementation research. So when we think about traditional research, we see in our first box here, and this was a framework first put together by Enola Proctor some time ago, but we have our sort of our EVIs, our evidence-based interventions, that could be condom promotion or HIV testing, empirically supported treatments. Those could be behavioral treatments. Those could be pharmacologics. And then normally we have then our sort of end or our second last outcome there. So it's like we only really measure, like, did they change a health outcome? Sometimes people have looked at the sort of research like, can you increase efficiencies, effectiveness? Implementation research is really focused on the 2 middle elements there. So one is, you have a condom promotion, and as we'll talk a lot about today, is like, how did you make that happen? And the implementation outcomes are really studying in a very granular way, how well did your approach to making that happen work? And then it fits within that framework then of, depending on how well those things went, it'll have some outcome related to service and some outcome related to health. I'm realizing that the titles actually seem to be showing up along the side of the presentation, but I'll just keep going. I'll say that there's sort of 3 main phases of work. And so one is really about analyzing missed targets. So often people are interested in implementation when a program didn't achieve what the program had hoped to achieve. And so the implementation research is really focused on understanding that disconnect between the expectations based often on efficacy data, so for example, around vaginal microbicides, and the effectiveness. And there we study these implementation outcomes that we listed on the last slide. So, they are looked to evaluate the implementation effectiveness. And there are these key intermediate outcomes between their traditional population level health outcomes and the actual program, like what we specifically did in each of these clinics. We can measure them quantitatively or qualitatively. And the constructs, often are, might be provider oriented. They can also be client oriented, but it's often, normally in traditional research, we only focus on sort of client issues. Here, we're starting to look more upstream at like what's happening at the provider level, what's happening at the system level. So let's just take PrEP as an example, because I think most folks are familiar with it. So we know PrEP to be highly efficacious if you use it and you are adherent. Obviously less so with moderate adherence. It is underused among adolescent key populations, including young gay youth and young trans youth, and PrEP uptake obviously is far from optimal. So when you're trying to figure out like why do these gaps exist, again, apologies for the formatting, but there's sort of the trial and error approach. It's like, well, I think the gaps are related to this because this is what I saw in clinic. You ask somebody, you call a friend, we say this is the who wants to be a millionaire type approach. You think about like what that might be. You write a grant. It finds out either it has a suboptimal score. Then you say, well, you know what, actually, like we should really do some formative work and try to understand this. Then you start understanding what it is. And then you realize, you know what, I really need a systematic approach to all of this in order to actually even approach the problem. So then asking from sort of an implementation research perspective is to say, well, why is there a gap between evidence and practice for PrEP among adolescents? And this is sort of the theory-based approach. Well, it's, you look at frameworks and theories in implementation science, and you ask, like, from all this work that folks have done, like, is there some reason why we think that this is happening? We look at those frameworks and theories, and I'll talk soon about those, either in social science or psychology, again, get some insights into why these barriers are happening. You really try to work on like looking at the literature to see what others have said, and then you apply your own contextual knowledge. You work with the other data that's out there. You make it consistent with the theory, and you really shape an implementation diagnosis. Like, what do I think is the main problem? It might not be the only problem, but it is the main problem that I'm going to take on with this research. Then you think about, how do I address that problem, and propose a research study then to really improve upon or address that problem, and again, really adds to the body of knowledge because it was systematically developed. Another way that implementation research is used is to develop a program. So here you might be at the earlier stages, there is no program yet, and you're sort of thinking about, like, how do I develop a program? And the first step might be, like, again, characterizing the implementation gap. Like, what is the problem that is not getting delivered? Are the peer educators not getting supported to do what they need to do? Are they not trained enough to do that? Could be a million different reasons, but again, it's important to be very specific about what those are. Describe constraints to bridging the gap. Do you need to start a better understanding of the gap? Do you need pre-implementation work to sort of better understand this? Finalize your strategy, really specify, be very detail-oriented about what it means, how much you're going to pay people, how much time they're going to spend with each client, what training they need, etc. Decide on an appropriate logic model that sort of underpins your strategy. Think about, is it appropriate to use an implementation framework to sort of guide the strategy? Have you considered generalizability, and have you considered the context in which you're working? Is there an evaluation framework that you might consider that can help you understand the success of your implementation, or ways to sort of iterate it and further scale? And really describe your implementation outcomes along the way so that you know what you can measure and what you might not be able to measure. So I will say this is really a growth area, but I'm just going to do a very brief overview of implementation frameworks. And sort of broadly, there's sort of three types of frameworks, and then quickly some background on theories. But I'll just say that there are implementation planning and process frameworks, implementation determinants frameworks, and then implementation evaluation frameworks. And then there's also theories that are commonly used within implementation research. So an implementation planning and process framework is often used to sort of describe or potentially later to evaluate steps along the implementation pathway. So this is at your earlier stage of developing this program, and you're really thinking about, like, what are the specific areas that I consider to be a problem? What are the ones that I want to address? There's multiple frameworks that you can use, and often what we tell folks is to get comfortable using one of those frameworks. So the EPIS, Exploration, Preparation, Implementation, Sustainment, that I introduced at the beginning of the talk. There's K2A, Knowledge to Action, in terms of research, translation, institutionalization. And then REAIM. And REAIM, as we'll talk about, can be used as an implementation framework. It can also be used as a planning and process framework to think about each of the steps that you really need to have in place in order to start your work. But there's many of these. The idea is not to be able to, not to necessarily know all of them, but to feel comfortable using one of them to really be specific about what it is that you're planning on doing, and how you eventually we'll talk about how you'll evaluate it. There are also implementation determinants frameworks. And so here you are specifying domains that have been recognized as important for implementation. And so here, this might be an existing program, and you might want to be studying these very specific elements. Doesn't mean that you have to study all of these elements that you identify, but this is these are different frameworks, I should say, that help you sort of tease apart all these different elements of why a program may or may not be working, and help you, focus your energy and your time to what it is that you might want to study. So probably the most commonly used one is the CFR, but there's also promoting action on research implementation and health research in terms of looking at evidence, context, and facilitation. Again, the idea isn't that you have to use one or the other, but if you look at each of these, for example, in CFR, there's these 5 domains. If you go to their website, there's lots of subdomains, etc. And all of it is really about guiding, like, what it is that you might want to focus on in terms of your work, because that as to be responsive to the barriers that you've identified. And then finally, there are implementation evaluation frameworks. And again, this is really now about like you want to evaluate how well your implementation did. So, you know, there's a condom distribution program and you're, you know, what you did was educate peer educators or fund peer educators or, you know, create supply chains, et cetera. But that you are now having an evaluation that is really well aligned with your actual strategy. And so these evaluation frameworks can help you do that and help you make sure that that alignment is there. So then thinking about theories, and I think, you know, often people feel like when we start talking about theories, a lot of clinicians and a lot of practice folks start tuning out, and I don't necessarily blame them. But I will say that these theories can be really useful to when you're asking this question, like, why did a program work? Or can help you predict if a program is going to work. That, you know, because I think the last thing that we want to do as practice-oriented folks is run some big program and then have it not run exactly or at all the way that we had anticipated. And so, you know, for example, the normalization process theory you can use in adolescent programs, and it can explain like what people may do and why they may do them when implementing a new program. And so it's not specific to that community, but it might be used to be able to sort of predict or at least understand why something does or does not work. And that why question can get very important. We often don't focus on it when things do work really well, but if things aren't working, I think folks are very interested, again, in terms of formulating that diagnosis as to what they can do to make things work better. And then finally, you know, implementation research is used to assess new strategies. So now you might be more in that sort of research frame and you're really thinking about like, how do I study and make programs better? And so broadly as definitions, like an intervention is a combination of evidence-based programs or elements that are intended to change behavior or improve health status among adolescents at risk or for living with HIV. And so, and I'll give an example just to help folks sort of tease apart. The implementation, right, is the use of one or more implementation strategies to introduce or to change evidence-based health interventions, so policies, programs, practices for adolescents within specific settings. And then a strategy is the most detailed one of those. So it's a systematic process to facilitate the adoption and integration of interventions. So the intervention may be like, it's a condom program. The implementation are like, what are the specific things that you did in order to make that condom program work? And the more detailed you get, the better. Implementation strategy is then teasing apart each one of those. And so just as an overview, intervention may be like, think of it as like you're driving a car. Implementation are like, what are all the things that you do that you may not even be thinking about that you do when driving a car? You're checking for the scenes around you, you're accelerating, you're braking, you're not paying, you know, you're not texting. And the strategy is each one of those elements. And the question may be, for example, in reducing accidents, like which of those things do you really want to focus your energy on in terms of being the biggest bang for your buck, in terms of improving driving? So I'm not going to go over this because I think this is a good example. People can also use the ERIC approach, which also specifies implementation strategies. But I think it's a nice summary of like, there's so many different strategies that one can use to improve health programs. So you might do individual provider improvement. You might pay doctors or allied health professionals more. You might educate them. You might accredit and license them. You can do household and community empowerment. You can provide organizational improvement, oversight. And so the idea is that you might, you know, you might be doing multiple of these things, but implementation research is all about specifying it and being very specific about it so that you can really ensure that you're evaluating how each of these things work. So as an example, you know, an intervention goal may be increasing viral suppression for young people living with HIV. Your categories might be, you know, intervention categories. You might be doing policies or a program, providing resources, educating providers. And the strategies may be like a policy change. So licensing certain clinics, provide secondary or tertiary treatment regimens for adolescents. A provider might be, you know, funding communities of practice for allied health professionals to increase adherence for programs. Resources might be checklists to support improved counseling and optimize ART choice among adolescents. So again, it's just getting to the very specific elements of what it is that you're doing. So as an example, like in effectiveness research, and I appreciate the titles again, were really, the formatting's not great, but in effectiveness research, your primary research questions are generally client-oriented and either at the individual population level. So you might study the coverage of a particular intervention and adverse health outcomes in question. So the number of adolescent people living with HIV that have access to ART that are virally suppressed. That might be the key outcome of interest. But in implementation research, it's focused again on like evaluating strategies that may be a mix of like intervening with providers or clinics or clients, of course, and focus on improving implementation outcomes. So the study may focus on measuring the impact of an intervention, improving a marker of implementation, and the secondary goal is about seeing whether that improved client-oriented health outcomes. So you might implement a blended digital and peer-based education program for ART providers that serve adolescent communities, and you might evaluate, your evaluation may be about improved knowledge among providers, and then only the secondary goal is like, did that improve ART choices and ultimately viral suppression? The types of questions that you may ask here also focus on like where you are. So, if you're in the pre-implementation phase, you might just be doing baseline surveys of PrEP use and acceptability, understanding preferences using, for example, discrete choice experiments. It might be that the program's already underway and you might do quantitative or qualitative work to look at the acceptability of the particular strategy that may be client or provider oriented, feasibility, might use program logs or audits and checklists, mystery shoppers. And then you might be at sort of towards the end. So you might be looking at like, the impact, penetration, sustainability of your approach. What number of sites actually implemented the strategy that you had proposed? Was it sustained over time? Did folks stop using it after you stopped paying them, for example, in the context of a particular program or research study? It could also be that the RCTs look very different, right? So, like what is your study goal? So in the context of a randomized control trial, you might be that a pragmatic trial is asking the question, like, what can PrEP do in the real world, right? An explanatory study often, and there's been the history of them, is what can PrEP do under idealized settings? Similarly, like an effectiveness question is like, well, what might, the effect of PrEP be in reducing HIV incidence among adolescent LGBTQ populations in the real world? Whereas implementation might be about understanding the uptake of PrEP among adolescent communities and with decentralized delivery. So it's like testing decentralized delivery, because we assume that if there is PrEP uptake, that it will decrease incidence. And so that we're not sort of doing HIV incidence, that our outcome is sort of upstream from that. So, a study design might be that you have eligible adolescent LGBTQ communities at venues willing to participate. The strategy is that you might be testing about providing PrEP at a community location versus referring adolescent folks to a drop-in center. And then you're evaluating the PrEP delivery system and PrEP uptake and adherence. But HIV incidence is not part of your outcome. That you really, have that alignment between what you specifically implemented and how you're evaluating it. So I want to take a quick interlude to talk a little bit about like what is the state of implementation of stigma reduction interventions, and how do we sort of approach some of these elements, and why is it relevant? Because I think a lot of folks on the call are interested in like stigma reduction, stigma mitigation, particularly as it relates to intersectional stigmas or stigmas affecting LGBTQ populations or those folks living with HIV. And so, we just did a very quick review of like implementation studies of health stigma reduction interventions in low-middle income countries. And then we assessed the reporting of those implementation outcomes that I spent the earlier part of the lecture talking about, and the description of stigma interventions. I'm not going to spend a lot of time talking about the methods. This paper is available. Folks can read it. But just to say, it was a registered, methodologically sound, systematic review. Throughout the review, ultimately, we were able to include 29 interventions from a total of 35 studies, and we excluded a lot of studies here just because there was no implementation outcomes reported. For example, we weren't able to access the abstract. It wasn't related to stigma mitigation, etc. Again, available in the paper. The point I wanted to make with presenting this was that, like, of all these studies, so in the 35 studies, that really none of them use a theoretical framework for implementation research. So as I spoke earlier about, like, all the reasons why that might be helpful, that a lot of these studies didn't use that, is particularly for stigma. None of them used established implementation outcomes. You know, there was a mix of qualitative methods, acceptability, very few assessed costs. In terms of like the actual interventions, they were mostly focused on HIV stigma. And I think increasingly we're understanding intersectional stigma to be really important. Less so focused on individual level stigmas, more about community stigmas. And most of the interventions, all but one, really used sort of like information education. But again, very few others did, you know, like things about all the other sort of intervention strategies that we've talked about. So just to end with sort of a few quick thoughts, because I realize I'm also a little bit over, is to say, one, you know, I think that the methods that we've talked about today can really help, I think, folks specify their programs in response to really specific gaps to improve health and HIV-related programs among adolescent communities in South Africa and beyond. I think there's a lot of planning and evaluation frameworks that can be used to really help further design these programs. There are these specific evaluation methods using a range of designs that can be helped to use to evaluate the health outcomes of the intervention or the implementation strategy itself. And then I introduced that element around stigma because I think there's really an opportunity to sort of like leverage these methods within things like stigma mitigation, these programs that are out there to improve the lives and well-being of young LGBTQ populations. And that we think will really promote real-world implementation and support things like evaluating cost and sustainability. So I wanted to thank folks for the opportunity to speak and really look forward to the Q&A today. Thanks.
Thank you so much, Prof. Baral, for that masterclass, really, in understanding the importance of not only implementation research, but the value of being specific in the questions that we ask, the aims we seek to achieve, and the role of granularity in our research. Colleagues, we've heard a lot of information in the last hour. So to recharge us all, we have another 60-second poll for you to respond to. But before I launch that poll, a reminder that next up is a panel discussion where we will hear reflections from our three guests on the presentations that we have heard thus far and engage with the presenters. And another reminder to please keep the questions and comments coming in the chat. The poll is now live. And we have 60 seconds. We'll close it at the top of the minute. Like everybody has voted, we have 90% of you have said that you believe implementation science can play a greater role in advancing the health rights of LGBTQIA communities. And 3 of you have said you're not sure. Some interesting responses there, colleagues. But thank you so much to our speakers. Colleagues, we'll move straight ahead now from there into our panel discussion. Allow me to introduce our 3 panelists. Dr. Anastacia Tomson, who is a medical doctor, author, and activist working for the rights of LGBTQIA+ persons. Amelia Mfiki, who is the community liaison officer at DTHF's Groote Schuur hospital site and one of the leaders who have established the LGBTQIA+ forum, working with different safe spaces and service providers of LGBTQIA+ populations in Cape Town. Her role is to engage with communities about new developments on HIV and related issues. And finally, Dr. Zoe Duby, who is a social behavioral public health researcher with a focus on sexual and reproductive health, HIV prevention, gender and sexuality, and health rights and equity. I will now ask the panelists to turn on their cameras and the speakers, if that is comfortable for you, and share some thoughts on the presentations we have just received. We'll start with Dr. Tomson, then move to Amelia Mfiki, and then to Dr. Duby. Over to you and welcome, Dr. Tomson.
Good afternoon. Thanks for the introduction, Tian. It's really great to be here and to be having this conversation. And, you know, I think it's such a nuanced space for us who work in the sciences, and who also identify at this intersection of queer identity, because, you know, we realize the importance of evidence and data gathering. We also have the lived experience of a group of people who have been marginalized and oppressed, and, you know, studied not necessarily with the intention of promoting or enshrining our human rights, but often really just for the sake of exploiting us or treating us as if we're lab animals, for want of a better term. And I think there's a lot of baggage that comes with it. And, you know, we can understand this sitting here in South Africa with our particular socioeconomic context, where we know that, you know, queer people are historically less likely to have those kind of opportunities, to have the stable housing, to have the access to education, to have the resources, in order to be at the helm of the data collection. So it's always been in the hands of others, you know, whether those are cisgender folk doing research on trans folk, or straight people doing research on gays, lesbians, bisexual people, whatever it is. And I think that a lot of the difficulty stems from that there hasn't been necessarily enough lived experience underpinning the design of these research projects. And, you know, I think the effects of that are manifold, but, you know, certainly one of them is that often the research that we've collected, or the data that we've collected, kind of misses the mark, because it doesn't have the understanding, the contextual sensitivity to the experiences of the communities, you know. And I mean, we have to look at this through an intersectional lens. You know, as I sit here and I have this discussion with you, I'm aware of my various intersections of privilege and marginalization. And I realize that if I wanted to collect information or do research with the aim of helping the trans folk in South Africa, I can't just look at my experiences, because I'm not indicative of every trans person in South Africa. And that community consultation becomes really important. I don't think it stops at consultation. I think that we need a concerted effort in order to really empower people in the LGBTQIA+ community to grow and develop into these fields and to become the leading researchers of tomorrow, so that, you know, when we look at this in 5 or 10 years, the research on us is being done by us. And it of course goes further than that as well, because it's not just about whether the research and the data collection is necessarily having the effect that we would want it to have, or whether we're asking pertinent questions, or whether we're naively making assumptions that will render many of our conclusions essentially useless. But we also have to understand the social context and the stigma around queer identity, because not only do we have to consider that people who participate in this research, or the subjects of this research, might be exploited by those conducting the research, but that society at large remains largely unfriendly and unwelcoming, and often downright violent towards people in the queer community. And in order to participate in research, you often end up painting a target on your own back. Your own personal, individual, physical, mental, emotional, psychological, spiritual safety can be jeopardized by that. And I think one has to realize that this process of data collection and research development needs to go hand in hand with social change. We can't uncouple them. These are two sides of the same coin. And the implication of that is that if you are doing work with this community that you and I are part of, if you're doing work with this community, engaging in research, collecting the data, whatever else it is, you also have a responsibility be a human rights defender and to be an activist and to understand the social context. Those are my opening comments. Thank you for the opportunity.
Thank you so much for sharing that. You know, I think it's such, you've really encapsulated and summarized so many years of the struggle so beautifully, really looking at what we've been saying for years now, nothing about us without us, nothing about us without us, and it almost becomes rote in parrot fashion, almost you feel it's going over heads, and never for research to happen on us or at us, but with us in the driving seat, and certainly the fruits of those research, of that research should be led by us. So thank you so much for so beautifully capturing that. I'm now going to move to Amelia Mfiki to share her thoughts on the two presentations. Welcome, Amelia.
Thank you, Tian, and thank you to the audience for being with us today. I think from my side, I want to put an emphasis on the fact that we are humans. The LGBTQIA+ persons are humans. And the LGBTQIA+ rights are human rights too. Now we need to think about building the families in the sense of accepting and family integration, because that is equal to life. We have people that have been rejected by the system, by the families, and they are living on the street because there is no space or safe space for them. Even when you go to these safe homes, there are criteria or eligibility criteria for one to belong to one of the safe spaces or the shelter, which at times it rejects the individuals. But because we have tried and establish the more of a coordination, collaboration structure within the City of Cape Town, where we have all the organizations that are working with the LGBTQIA+ people within our communities. We believe that is a structure that needs to be advanced more, because we're already operating and we're inviting all these organizations that are working within our population to be part of us, so that we can talk in more of a united voice. There are two things that we are battling with as the forum or as the organizations. One is the implementation of the programs once the studies are successful. Let me give an example. SAMRC approved oral prep years ago, but when in terms of implementation, one, it's either it's genderized, that it's young girls of this age and this age, or if you're at risk, so you cannot just feel that you need prep and you go and access prep. Is it something about the cost? Is it something about the attitude? Is it something about the willingness? Those are the questions that we need to ask ourselves. And what is happening within the rural areas that are not within the communities, or that are not in urban communities where everything is accessible. Recently, I think in December, FDA have approved the injectable PrEP in developed countries. The question is, how far are the African countries with that? Particularly South Africa, if I were to be specific. Now, if oral PrEP was approved years ago and still we are struggling to access it properly, how are we able to implement or learn from that exercise? As to say, we are not waiting for the data analysis for us to start engaging with the implementation department. We need to start engaging with the implementation department once the ethics approves for the countries, so that at least our countries are prepared on time. Not to have all these delays because communities are not ready, finances are not ready, and all these excuses that are made put in. Now, this is the time for the communities and for the authorities to start thinking as to how do we then do better for our adolescents, because this is a young age that is living in a sensitive life, and that want to explore life the way they want, but the authorities and the systems are failing our communities. What can we do best? So that is what we are looking at. Recently, we just, I think in December, we had an activity where we were trying to have a link between the research, the service provider, and the communities as beneficiaries, as to say, how do we know what is happening in South Africa? And how do we link the research to the service provider and to the communities, so that the give and take attitude that we are receiving in some institution and in some communities, at least we eliminate and iron out that. So those are the conversations that we need to have, and we need to acknowledge the community involvement. By that, I mean whatever recommendations that the communities are saying it out when there are consultations, those recommendations need to be acknowledged and actioned at times. Yes, it's not going to be happening all the time, but communities need to be acknowledged. Thank you so much. That is my take on this.
Thank you so much, Amelia. You know, I just really want to take this moment, colleagues, to really just honor individuals like Amelia, you know, the leadership, the courage, the passion, the work of the forum. Because I think at the core of what we are seeing today is not just Amelia sharing her own experiences and the experience of her context and the forum, but at the core of it is the call that we have been making for years, for decades, that absolutely we have to urgently dismantle and destroy the privilege and the exclusivity of research and how research happens and where research happens. Because truthfully, today we are in a situation where we can see the results of detached research. We can see the fact that communities who have participated, for example, in COVID-19 vaccine trials are looking on without access. So we want to reiterate that call from civil society to actually say, we want a new understanding, a new level of consciousness of researchers, to say, this cannot be research for research's sake. We have to approach research in every single instance with a view to access, with a view to equitable access. Communities want to benefit from the rewards of that research. So just really a moment to honor and just really center the work, the leadership, the courage and the strength and the wisdom that Amelia brings to this discussion. So thank you so much for sharing that with us, Amelia. Colleagues, I'd now like to move to Dr. Zoe Duby to share her thoughts on the presentations and comments and reflections that we've heard thus far. Welcome, Dr. Duby.
Thank you, and thank you to all the speakers and my co-panelists. It's been really such a valuable and rich and diverse discussion so far. So I just wanted to reflect firstly on Tandile's beautiful piece. And what touched me about that, I think specifically, was in the Southern African context, we often see culture and tradition pitted against any idea of queerness, almost as if there's this conflict that the two can't coexist. And I've seen that in my own work. And so it was very beautiful to see, for me to see that sort of synergy between traditional culture and a sort of queer identity being so beautifully expressed. So thank you, Tandile, for that. And yeah, I think Neil's work on intersectionality, I think, really struck a chord as well. And this discussion about inclusion and exclusion resonates in the sense that I'm always very interested in the language and the terminology we use. Even this acronym that we're using today of LGBTIQ+, I struggle with some of these terms and these acronyms, because there are always people who are excluded necessarily by whatever category we use. We are creating these boxes, and sometimes there are people who don't fit neatly into any of those boxes, and they often, I mean, Neil spoke about the sort of siloed aspects of services, for example, and we see MSM clinics and men who don't identify as gay don't want to go to clinics. Like, there's those kind of issues with identity. And does it really reflect the fluidity of humanity and human experience? And I think Anastasia's comment about the lived experience. So we do know there are multiple sort of intersecting levels of stigma and discrimination experienced by many key population groups and LGBTIQ+ and others. So how do we effectively, in our research, do we keep perpetuating these categories and these concepts and necessarily excluding people who don't neatly fit into those? That's something I'd like to make us sort of think about whenever we use these terms. And there has always, I mean, even the LGBT acronym has been growing as we've seen it, LGB and then the T and then the I and the Q. And sort of, are we assuming commonalities in experiences? There are some, but an intersex individual might have a very different lived experience to a lesbian, for example. So there are certain assumptions made when we lump people together. So I'm just wanting to challenge these concepts that we sometimes use. Neil also spoke about adolescent girls and young women, for example, having the highest HIV rates in the country. So how do we think about vulnerability of a group who are not traditionally a key population or not a sexual minority group, and understand vulnerability and risk in a sort of broader sense, that we capture people who aren't in any of our neat boxes. And I think that brings me to reflecting on Stef Baral's very interesting piece on implementation science, and how do we, there's not only is it a gap between those people being researched, the researched and the researchers, but there's also such a big gap between academia and policy. And how do we make these communication links, these translation links? That research translation is often not sufficient. It's not acceptable the way it happens, and all the politics that are involved in publishing papers. And how do we then feed that into the people who are actually making policy, to government, people in the government seats, who often we can have a wonderful set of policy recommendations about inclusivity and addressing sexual rights and so forth, but the people making those decisions are not themselves equipped with the knowledge and understanding of these issues to really, or even the acceptance of them to really action those recommendations. So how do we address those gaps in research translation? So all of these, to me, what the commonality across all the presentations and discussion was around inclusion and exclusion, and just being mindful of every space we create that is supposed to be a safe space for one set of people. Is it necessarily excluding someone else who's not neatly in that set? But thank you, everyone. I've really enjoyed being part of this today.
Thanks so much, Dr. Duby, for sharing those thoughts. I think you've done a great job of holding us accountable as well. The violence really of categorizations and what that means. But I think also, as we discuss that potential violence of categorizations, we would also need to acknowledge the role of the international donor community and how the money flows in order for research to happen, and how that has influenced and perhaps even advanced with where we see ourselves today. Colleagues, I'm very mindful of time. I know we have 15 minutes left. I would like to just raise a few questions that are in the chat, and then I will hand over to Professor Baral and then Neil to do two things. The first would be to reflect on the overall comments shared and address their specific questions, and we'll move to closure. So we have a few questions in the chat. I'll start with a question here that we have from Anna. Mike, what needs to be done? So this question addressed to Prof. Baral. What needs to be done so that we can see an end to the struggle of making sure that the evidence to implementation gap is urgently closed? A comment again from Ruben, speaking about the exclusivity of science and research and what that means for activism in particularly hostile environments like Zambia. Then a question from Anna for Neil. What opportunities exist now to bridge the urban-rural divide in a place like Cape Town so that queer folks who are not urban dwellers also benefit from the progressive interventions you described? Ruben also here highlighting the SADC strategy on SRHR and HIV and AIDS and the importance of a regional approach, but also reinforcing the need for quality interventions on the ground in country. So I'll hand over now to Prof. Baral to give some reflections and thoughts on the feedback to your presentation, as well as address some of the specific questions. Over to you and welcome again.
Thanks very much, and indeed, a very powerful conversation. I think, so there's a few thoughts, and I think it kind of ties the point that Anna was making together with some of the others, which is that, I think implementation research emerged because a lot of the research that was being done was not reflective of community wishes, community desires, and thus ultimately wasn't translating to, kind of real world effective programs. And so I think PrEP is kind of like the prima facie example of that, where in research studies, it's highly efficacious, and in real world settings, it's not achieved, I think, what many folks had hoped that it would achieve. And a big part of that has really been about, I think, not understanding and not having community at the leadership table in terms of even the design of the studies, the questions that were being asked, the designs that were being used, and then the sort of outcomes that were being measured. And I think now we're seeing more of that happening. I think that there's been sort of a change that when you look at like the core research team, it's important that it isn't just representative of like folks with MDs and PhDs but really has a broader leadership structure, and people are funded to be on that, not just as a community advisory board, but really as leaders of studies, to then really inform like what they should be asking. Because I think when we do that, we get closer to asking questions that are going to have real world implications. And so it might not be apparent to researchers that the biggest challenge to PrEP delivery is like where it's being delivered, or how it's being delivered, or how it's being messaged, why it's not reaching certain folks. And I think when you get into when you ensure that you have this sort of comprehensive and meaningful leadership structure, you're more likely to be able to ask those questions that are meaningful, and then provide very detailed answers about how to deliver PrEP in a way that is consistent with community desires and community needs. I think that is another great example, is that often research has not, and this is why I wanted to introduce the stigma piece, is that often we've not paid as much attention to evaluating the impact of stigma interventions in particularly hostile environments. And so we've done these interventions, and then we feel like, well, we did a stigma intervention, like a box has been checked, and you can report to UNAIDS that you're achieving zero stigma, but we've not paid attention to really evaluating, like, did that stigma intervention work? Was it, did it help community access services? Did it help with the mental health and well-being and just general quality of life of community members? And I think we need to kind of get to a more structured way of asking these questions. Again, very consistent with community leadership, so as to ensure that like we're doing better on stigma interventions and trying to improve these hostile environments. Because I think increasingly UNAIDS and PEPFAR and others are understanding that like the biggest barrier to achieving goals in terms of mental health and well-being and HIV outcomes at this point are structural issues, are structural barriers for particular communities, even across sub-Saharan Africa, across the United States. There's a focus on saying it's not just about a new drug, it's not just about a better condom. It's really about what are the barriers to existing services and how do we do better to overcome those. So I think the conversation today was incredibly important. Implementation science, by definition, is really hoping to learn from community, be informed by community, and be led in partnership with community. That doesn't mean it's always done, but I think that is the intent of it, and I think it's what the field strives towards. But indeed, I think that the questions that are being asked are about really aligning what we know to be useful. Like if somebody uses PrEP, they will not acquire HIV. If somebody is on treatment, they will not transmit HIV, and really then trying to understand how to make that more real and function in real world settings. So thanks.
Thanks so much, Prof. Baral. You spoke to my heart when you spoke about structural issues, and now certainly we've seen this in COVID. We've had people collapsing in vaccination queues of hunger, and we ask ourselves, well, why did we think this was going to be different? Where did food security automatically, magically come from in the context of a COVID vaccine, where it wasn't in the context of adherence to treatment? So absolutely. Thank you so much for those reflections. Colleagues, I'm going to hand over now to Neil Hassan to respond to the question, as well as share some general comments on the feedback that we've shared so far. And welcome again, Neil.
Awesome. I just want to thank everybody for the amazing input so far. I am humbled and very encouraged at the same time. I think what is important to acknowledge is that a lot of the NGOs are funded, and these funding comes from outside of South Africa. And accompanying these funding is also very specific indicators. And so people are responding and searching to respond to the indicator instead of looking at the fluidity of humanity, to use Zoe's term, which I also appreciate. But what I want to point out is that these these indicators do not take into account cultural factors. For example, African spirituality do not play a role in these indicators. It does not play a role in the long-term sustained effects of intervention. We know that from our previous webinars that among women, PrEP is highly, the uptake of PrEP is amazing, but the adherence to PrEP is not that great. And we find that across the board, right? We know that the first two 1990 or 1995s that we are searching for and that we are calling to respond on in the cascade is promoted much more than the last 90 or 95. Those linkages, those key relationships that are formed between NGOs and community members, NGOs and leaders, are not being translated to our people who are sponsoring our work. And many a times these experiences are excluded because mostly the work that is reported is quantitative. So how do we turn the lens back on who sponsors these projects in Africa? And how do we say to these people, we know what needs to be done, we know how it needs to be done, we know where it has to take place. But these funding mechanisms, these policies, these strategies do prevent us from doing that. For example, so many of the NGO programs in Cape Town do focus on urban spaces, right? Rural spaces are not that much promoted currently, but because NGOs do have large networks that expands across the entire country practically, they draw on these networks, these leaders in other spaces, in Stellenbosch, in Paarl, on the garden route, to draw in people from the outside into urban spaces. And to some extent, this is, we still need critical engagement around this, because we've got 8 health districts in Cape Town, and most of the work is very much tuned to these 8 districts. Outside of these 8 districts, people are bringing from rural areas people into these districts. And so I think that's still a very powerful way in which NGOs are to some extent saying, we are taking control. We are not waiting to hear from departments of education or strategies to tell us we can bring in rural people. There is an agency that is happening at the NGO level, at community level. And I think those who sponsor HIV health programs need to start listening to that form of agency as the driving force behind implementation, behind programming. Thank you.
Thank you so much, Neil. I think you just hit the nail on the head. And I think with all of these discussions, we keep on being brought into this kind of global context and understanding this within a broader landscape of decolonization of health and how we experience health and how health is funded and researched and realized by all of these communities. Naomi Hill is raising really important points in the chat box around the importance of not only looking at the role of international donors, but also our own Department of Social Development, our own Department of Health. I think we've all had a range of experiences with these bodies, but I think our role as activists really behooves us to ensure that we keep pushing that accountability framework to ensure that the structures that have the resources really put those resources to where they have maximum impact. Colleagues, it's been such a deeply insightful, multifaceted, my head is spinning in a good way, discussion that we've had today. So I just want to thank you all so much for attending today, for your interest and your engagement. On behalf of the Desmond Tutu Health Foundation, IAVI, who has generously sponsored this series, and the African Alliance, I'd like to thank Stefan, Neil, Tandile, Anastacia, Amelia, and Zoe for your thoughtfulness, your preparation, and the passion that you bring to this work, which for many of us goes beyond a journal article, a plenary address, an op-ed, but it materially shapes how we as queer communities live, love, and thrive in a world that persistently seeks to dim our light. It is because of allies, partners, and thought leaders like yourself that we are able to gather and push ahead to see another day. Acknowledgement also to Carrie Pike, Melissa Wallace, for ensuring today's discussion went as smoothly as it did. Please note, colleagues, that as you exit the Zoom platform at the end of this webinar, a very brief evaluation will pop up. These evaluations help us do better the next time. Thank you for taking a moment to complete it. Your feedback will help us improve the webinar series going forward. The session has been recorded and will soon be available on DTHF's YouTube channel. So on behalf of myself and sponsors, thank you so much for spending your Thursday afternoon with us. We hope that you found this as valuable and insightful as we all have, and we look forward to engaging you further. Thank you so much, everybody. Have a great Thursday.